This lecture is going to be addressed by Adriana Fernanda Segura-Zenón from Mexico. So please, Dr. Zenón, go ahead.
Sure, thank you. Let me know if you can see my screen. Yes, okay.
Thank you.
Well, greetings from Mexico City. I hope you're having an excellent day from wherever you're following this session. I am really pleased to be here, and I want to thank Dr. Naren for this space. My name is Adriana Segura, and I'm going to talk about microvascular decompression for glossopharyngeal neuralgia in a single center. So I am going to start with a short definition of the glossopharyngeal neuralgia. It is a disorder characterized by unilateral brief stabbing pain, abrupt in onset and in termination in the distribution of the glossopharyngeal nerve. And pain, it will be experienced in the ear, base of the tongue, tonsillar fossa, and or beneath the angle of the jaw. And I think it's really important to talk about a background over the years from this pathology. So I'm going to mention some interesting data. In 1910, Weisenberg first described glossopharyngeal neuralgia as an essential pharyngeal pain. Then in 1920, Sickard and Robinow were the first to describe a surgical intervention for patients with glossopharyngeal neuralgia by dissecting the pharyngeal nerve and the branch of the vagus nerve in the neck. 7 years later, Dandy performed an intracranial rhizotomy of the glossopharyngeal nerve as a treatment. And then in 1977, Janetta observed compression of the glossopharyngeal nerve by the vertebral artery, and that's how the etiology of this disease became known. After that, Laja and Janetta initiated the first non-destructive treatment for glossopharyngeal neuralgia, giving rise to microvascular decompression in the posterior cerebral fossa. So now that we have this summarized background, I am going to present our work. And the purpose of this study is to describe our results of the microvascular decompression to treat glossopharyngeal neuralgia, as well as to inform the surgical findings and the outcome of our patients. So our method was based on a period of time from August 2016 to October 2021, where 94 patients were diagnosed with glossopharyngeal neuralgia, where 37 of them were diagnosed with glossopharyngeal neuralgia in its classic form, and 57 of them in combination with other neuropathies, of which 29 patients was our sample in this studio because they are patients who underwent microvascular decompression and fulfilled the inclusion criteria, such as a complete clinical record, MRI disc, surgery report with video and drawings, and also histopathological reports. And age, sex, time of evolution of the symptoms, intraoperative finding, and postoperative results were evaluated in this studio. So here you can see a video where Dr. Mauro Segura is realizing the microvascular decompression of the glossopharyngeal nerve. You can see it here. And also you can see that the cisternal segment is identified in its exit prior to the jugular foramen of the glossopharyngeal nerve, and some fibers here of the vagus nerve on the right side. Towards medial deep, contacting posterior inferior cerebellar artery was identified. Then it was dissected, and finally isolating material was placed to avoid this contact. Okay, so now that you see the technique, we are going to talk about our results. And the mean age of patients with glossopharyngeal neuralgia was 56 years old, with ranges from 33 to 76 years. And the average time of evolution of the symptoms was 7.5 years, with ranges from 1 month to 23 years. Also, there are no statistical significant differences in gender and inside of the pathology, different from the trigeminal neuralgia, where female and male ratio is 3 to 1. So talking about comorbidities, it is important to mention that it is presented in 52 of our patients, where we can highlight systemic arterial hypertension, diabetes mellitus, and dyslipidemia. But it's also important to emphasize that these comorbidities do not affect on the evolution of our patients. And also, as you can see, the incidence is as in the general population. So talking about surgical vascular findings, the leading cause of compression was the superior cerebellar artery, followed by pica, ica, and vertebral artery. About the histopathological findings, we include arachnoiditis presented in 92% of our patients, where it could be viscous fibrosis or with microcalcifications. But this microscopic information with histopathological findings will be reviewed and analyzed in another study to relate how they affect on the evolution of our patients. Now, talking about the diagnosis, it will be clinically, and MRI will help us to confirm or support our diagnosis. Nevertheless, a vascular contact cannot always be observed until surgery. So look at this 3D Fiesta MRI at the level of the jugular foramen, and note the right side of a patient where we can see how vascular contact looks like here from posterior inferior cerebral artery, better known as pica, that is a direct branch of the vertebral artery. So now talking about to the postoperative evolution of these of the first 48 hours of our patients who underwent surgery, vomiting, nausea, headache are the most common reports of our patients in 60% of them, and major complications such as cerebrospinal fluid fistula occurred in one patient, and he required a reoperation. Also, just one patient present transitory facial palsy. But as you can see, there is just a minimum number of patients with this postoperative evolution. So we use the following classification to capture the results for having a registration of our outcome. And all our patients present immediate improvement of the glossopharyngeal neuralgia symptoms after surgery. Almost 70% of them reported themselves without pain. 6.9% of our patients report themselves with mild pain, but no medication requirement. And 10.3% of them reported moderate pain adequately controlled with medication. And here I would like to emphasize that these patients have been using drugs that do not relieve pain for years, on average 7.5. And now after microvascular decompressions, they do not need any drug, and it's finally controlled the pain with medication. And finally, we got a 6.9% of our patients that were candidates to radiofrequency thermoablation due to the residual pain. So as a conclusion, we conclude that minimally invasive microvascular decompression as the first selection surgical treatment for glossopharyngeal neuralgia is the most effective and safe surgical procedure, allowing a good resolution in most of the cases, 93% of them. And we do not recommend neurotomy or rhizotomy of the glossopharyngeal nerve due to the transient secondary sequelas, and a more detailed analysis could be done in order to find any possible relation among the surgical and histopathological findings with the long-term outcome. So finally, I want to finish this session with Matilde Petra Montoya. She was the first female doctor in Mexico from the National School of Medicine, where in those times the participation of women was not approved, but Matilde fought to achieve her goal of being a doctor, and before 1887, there was not a single female physician in the entire country, so she made history and forever changed the course of medicine So thanks to her, doors were open for many Mexican women on the path of medicine, science, and knowledge. Thank you very much. Here is our email where you can write us and leave us any question, and we will be very pleased to answer all of your questions as soon as it's possible. Thank you so much.
Dr. Segura, thank you very much. And congratulations. Excellent talk. Very well presented. Very good results. Congratulations. I have one question, but maybe my co-chairman wants to make any comment or
yeah, thanks, Miguel, and thanks, Adriana. That was a very good talk, and thank you for bringing up this topic because it's not as common as trigeminal neuralgia or hemispatial spasm, but we do still see the cases with significant morbidity related to this problem. And I have to say the number of 94 patients quite impressive. It's almost in about 5 years' time. The only question I have also about the histology, the microcalcification. Where was the histology taken from? Was it around the adjacent structures around the glossopharyngeal nerve? So do you know where the biopsy was taken, Adriana? I think you're muted.
Adriana?
I think she's muted.
She's back.
The biopsy with the calcification and the fibrosis, where was this actual histology taken from? Was it around the tissue of the nerve?
Yes, these biopsies were taken from at the microvascular decompression moment. So they are taken from the arachnoidaries that are found at the surgery.
Okay, thank you. Yeah, I think there's nothing much more for me to add. I can see Andre. Andre, you want to? Andre?
No, thank you, Ramesh. No, I enjoyed all these talks, and the last one was very impressive. I think I agree with your question because sometimes we know you can't take a biopsy where you would like to do because it is difficult, because when it is very adherent, you leave it alone. And probably if you would be able to take that, you will have other histology findings. But nevertheless, this was very interesting, also very good good results, to be honest. For such an amazing number, indeed. I haven't seen that many cases in all of my career. Yeah, very nice.
I think if I may make a comment, I know Professor Segura for now about 25 years. We met at the North American Skull-Base Society around the middle 1990s. And it's what I want to mention is that, you know, it's very, very generous of him to get his team to present, and same was with Professor Yek and Angeli, because whenever you come to pediatric neurosurgery meetings, most of the time the consultants are presenting the work. So first of all, thank you to Professor Segura to get his team to. Is Professor Segura, do you want to make any comments, sir?
No, everything is okay.
Okay, great. Thank you. Excellent. So the second, Miguel, I'll leave it to you, Miguel.
Thank you. Thank you very much, Dr. Segura. Very nice presentation. And I think we all have been having the same issue in our mind, the issue of the histological finding. That is something surprising.